Hi, I'm Anton Pozniak from the Chelsea and Westminster Hospital and the London School of Hygiene and Tropical Medicine, and I'm talking about the Reprieve study. This was presented at the IAS in July this year, 2023. Now, it's a groundbreaking study in my opinion. Firstly, why did they do Reprieve? Well, the cardiovascular risk in HIV patients is thought to be double that of the general population. Some of it is due to perhaps excess smoking and other risk factors, but people believe that residual replication in people who are HIV positive causes inflammation, and that inflammation can lead to cardiovascular disease. So the Reprieve study group decided to do this research, and what they did was ask a question. The question was, if you give a statin to patients with HIV who normally would not receive it, they're at low risk of cardiovascular disease, would you have an impact on resulting episodes of major adverse cardiac events? So they randomized a large number of people, and when I say large, we don't see many studies like this in HIV anymore. It was 3.5 almost thousand patients in each arm, placebo or privatistatin, a statin which, although you may not have heard of it very much, has got some anti-inflammatory property and no interactions with antiretroviral therapy. They did it across the world. All the continents were basically represented in this study, and they also included a large number of women in the study, and they even had a couple of percent, 2% of transgender people inside the study. So the study was very comprehensive, and it was running, and after 5 years, the Data and Safety Monitoring Board said, hey, we have to stop the study because the results were so good. Now, what were the results? Well, the DSMB saw the primary endpoint was that there was a 37% reduction in major adverse cardiac events, and also there was 21% reduction in deaths if you include those and cardiovascular events. And so I can understand why the DSMB stopped the study. So when you look at the detail of this, you might say, well, hang on, we should give all our patients with low to moderate risk of cardiovascular disease, we should give them all statins. But of course, we just have to wait a little bit to look at more of the data as it evolved. Was there any real difference between all the subgroups? Well, the major one, if you had a risk of less than 5%, there was less benefit than those who had 5 to 10% risk of cardiovascular disease. And when they looked at the number to treat, the number of people you needed to treat to prevent one episode of a major adverse cardiac event, it was overall 106. But when you looked at the higher risk people, those with a 5 to 10% risk, that was around 50. Now, what's the downside? Well, as I say, we don't have all the details, but one of the downsides is that we know with statin therapy, there are side effects. But there were really no big difference in the side effects in terms of stopping the drug between the privatistatin group and the placebo group. But there was a slightly increased risk of muscle pains and aches. We know that can caused by statins. And the diabetes risk we know with statins is there. But privatistatin only increased above placebo, about what the background population might get in terms of diabetes as they age, only a 1% increase. Now, when you calculate the number needed to harm by the privatistatin to cause diabetes, I did a quick calculation. It was about, you needed to give 70. So that's quite a high number, which is good. So overall, I think that we've got a long way to go, because there's lots of other questions about if we're going to change the guidelines to say that people with low to moderate risk are going to need a statin who are HIV positive. We're going to need to know some of the more detail. Was the geographic distribution fine for everybody? Who's going to do this? Is it going to be infectious disease doctors, family doctors, HIV specialists? Who's going to prescribe the statins for people? We also need to know more about the women, because tended to have more inflammation and less plaques in their arteries, yet they had a very good benefit from this. So we need to know more about the subgroups as to how we might adapt this study. The other problem will be, do we have a public health approach in places like Africa and Southeast Asia, where cardiovascular disease is prominent and on the increase, and sub-Saharan Africa as well? Do we say we should have this public health approach where everybody gets it, or everybody over the age of 40, because that's what this study looked at, 40 to 75, should get a statin? We don't know that, because some of us who work in more resource-rich places will be able to tailor what we do. And finally, I think the statin study has shown us not only that we can do long, very good, excellent studies, but it's also focused perhaps a bit more our minds on our holistic patient's health and how we might help them stop smoking, exercise more, and stop eating ultra-processed food. Because this would be something that we can start putting in train, and the statin would just be one small piece of their jigsaw, very important parts of the jigsaw in terms of healthy living. Thank you.